Welcome, everyone. My name is Jessica Nettles, and I am the Community Outreach Liaison for the VNA. I would like to welcome you all to our second hospice webinar titled The Importance of Advanced Care Planning in honor of National Healthcare Decisions Day. So the purpose of these hospice webinars is to help our community get a better understanding of hospice support and the services that we offer here at the VNA. And like Sue mentioned earlier, at the end of the presentation, we're going to have a Q&A session and answer some of the questions that we received from some of our participants when they signed up for the webinar, and any questions that we receive within the chat during the presentation. So tomorrow is April 16th, which is National Healthcare Decisions Day. And this day exists to inspire, educate, and empower the public and providers about the importance of advanced care planning. National Healthcare Decisions Day is an initiative to encourage individuals to express their wishes regarding healthcare and for providers and facilities to respect those wishes, whatever they may be. I would like to introduce today's speakers. So we have Genevieve Introcaso, who is a licensed clinical social worker and the advanced care planning specialist for the VNA. Abigail Binkley is a board certified family nurse practitioner and the clinical expert on the advanced care planning team. Both Genevieve and Abigail hold a special certification in hospice and palliative care, and together their focus is on empowering patients to voice their healthcare goals and offering guidance about options available as they navigate their unique journey. Abigail and Genevieve, take it away.
Thank you so much, Jessica, and good morning, everyone. Thank you for that wonderful review of National Healthcare Decisions Day and also the introduction. We were thrilled when Jessica and Sue had approached us to host this webinar, because I feel like we really try to celebrate National Healthcare Decisions Day every day. Advanced care planning is very much a topic that is near and dear to our hearts as the advanced care planning team for the VNA. So we're really excited about sharing with you some information about advanced care planning. Bear with us one moment. There we go. So just a general overview of what advanced care planning is. Really it's the thinking about, considering, starting to discuss what types of healthcare you may or may not want, and in particular, identifying who you would want to speak for you and who would honor those wishes if you were to ever become unable to speak on your own behalf. We always emphasize the right to self-direction, empowering independence and autonomy, because these choices really are yours and yours alone to make. They should be based on your personal values, your preferences, and as much as you choose to, the discussions with your loved ones. And that's a definition adapted right from the National Hospice and Palliative Care Organization. So just a general understanding that advanced care planning is exactly that. It's starting to plan what types of healthcare you may or may not want if and when you come to a circumstance where you need to make some of those decisions.
So let's go a little deeper and talk about why this is necessary. We're now at a point in 2022 where people are living longer than they ever have in all of history. And we add on to that oftentimes many of those remaining years, the last years, people are dealing with chronic illnesses, some of them pretty severe. We add on to that now in 2022, there is a myriad of options available for different treatments. It seems like anytime you open a magazine, see any kind of advertisements or commercials, there's a new medication being offered for treatment of lung disease, treatment of heart disease, chemotherapy, immunotherapy, so on and so forth. In addition to that, we now have more systemic challenges due to our healthcare system being so overburdened. I think we all can relate to that. You know, you make an appointment to be seen by a provider. Sometimes you've had to wait weeks or sometimes months to be able to get the appointment. You arrive for the appointment and often have to wait in the waiting room for a couple of hours. Then to have an audience with a provider for maybe only 10 or 15 minutes. So that's not a lot of time to unpack some pretty hefty and weighty issues often. And then surrounding all of that, we still have a lot of persistent myths and taboos about disease, chronic disease, death and dying, and sometimes things like hospice.
Mm-hmm. So talking through, if we've identified the need for advanced care planning, what is it that addresses these needs? What does advanced care planning include? And first and foremost, as Abaco had touched on, you know, the various treatments that are now available in today's medical system really complicate sometimes choosing between what types of treatments we may and may not want. So first and foremost, advanced care planning typically includes getting information on the types of life-sustaining treatments that are available. You know, once we have that understanding of the available treatment options and clarifying that sometimes that means alternatives to traditional treatments that are being offered, having the opportunity to talk through, process, and reflect on what types of treatment you would want. And we clarify here that advanced care planning really is beneficial for everyone at any age. But in particular, for those that are, you know, middle-aged and above, but also anyone that has been recently diagnosed with a life-limiting or chronic illness. Because of course, we want to have an idea of what we would want, you know, always being prepared should we experience anything like an unforeseen catastrophic event. But definitely, we want to give great consideration if we have been diagnosed with a life-limiting illness. What types of treatment would I want? What would I not want? What will my quality of life look like that might cause those wishes to evolve? It's so important that once you have an idea of your wishes, that you share that not only with your loved ones, so that there can be a consensus amongst family and understanding of what your wishes are, but also your care providers. You know, moving forward with the opportunity to put these wishes into writing. So much of advanced care planning certainly does include putting that into formal advanced directives. Things like our living will, our healthcare surrogate forms, and sharing them with your medical providers. So your physicians, your nurse practitioners, anybody that might be involved in your care and have influence in the decisions that may arise. You know, we pause here to speak specifically a little bit about those formal advanced directives, because sometimes even the terminology can be confusing. Oftentimes we'll hear the living will, perhaps mistakenly termed the last will and testament, you know, clarifying that the living will is the document that outlines our healthcare decisions, whereas the last will and testament is specific to financial or estate planning. Clarifying that our healthcare surrogate is who we identify to advocate for our wishes that are outlined in the living will, whereas something like a durable power of attorney is someone who has more financial authority in assisting with our affairs. I don't think we'll be able to view it clearly. Let me just give it a shot, but we do have a form. Let's see if we can see it here, maybe a little bit. But know that these are available. I think it just covered my face, but covering my face was what we call the 5 Wishes booklet. And in the state of Florida, this is a resource that we use often because it's a very user-friendly document that would suffice not only as the living will, so again, outlining what types of healthcare treatment you would or would not want, An example of that might be artificial nutrition, artificial hydration. Would I want to be placed on a ventilator if I could not breathe on my own? It's a very easy way to document, put into writing, as well as add some handwritten details about what you would want in those healthcare scenarios. It also offers the opportunity to complete your healthcare surrogate form, sometimes also termed your proxy. You might hear that term used as well. In this instance, we emphasize the importance of choosing this person because the healthcare surrogate is expected to use something called substituted judgment. So for instance, if I were to choose Abaco, my trusted friend and colleague, as my healthcare surrogate, it's because I have no doubt that she will act on my behalf as if she were me, following the guidance that is outlined within my living will. Not that she is going to make decisions based on what she thinks is in my best interest or based on what she would want. Again, reinforcing that these are our decisions to make and they should reflect our personal values. So the 5 Wishes is a wonderful resource that is available in the community. I clarified too that it does not need to be notarized. It simply needs to be witnessed by 2 non-family members, really no one who has a conflict of interest. So they couldn't be a healthcare provider involved in your plan of care. But then that would suffice again as your living will and healthcare surrogate form. You would want to keep the original copy and then provide copies of that to your healthcare surrogate and your care providers. The other piece, and I'm going to ask Abaco to speak to this in detail, because sometimes, although the 5 Wishes or the living will outline the preference for or against CPR. So sometimes that's referenced as code status. So if my heart were to stop, do I want them to attempt CPR to bring me back to life, or do I not? And what we need in order to carry that out in everyday practice is something called a DNR, a Do Not Resuscitate form. Again, I'm going to attempt to show this on the screen. I'm not sure if it's going to be viewable, but it's a yellow piece of paper that is necessary. It's actually a physician's order. So I'm going to ask Abaco to speak to what does this mean? You know, because sometimes thinking about this, it can be scary, you know, making a decision ahead of time of what I might want in one of those situations.
So I'm always happy when we have the opportunity to go a little bit further and talk about the DNR, because it's a point of confusion for many, many patients. In fact, I would say oftentimes the majority of patients of what it is and what it isn't. And as a healthcare community, we don't necessarily do a good job in explaining it, especially in the hospital setting where a lot of people encounter that for the first time. So the DNR, as Genevieve mentioned, is a formal doctor's order in the state of Florida, and it is only valid if it is signed by the patient or their representative and the physician, and it's on that yellow form. What that means is that it is permission, a medical order of permission to not attempt to bring somebody back to life if they have already died. And why that's important is the DNR, the Do Not Resuscitate, only goes into effect if somebody has actually already died. So in other words, you know, God forbid that I walked into Genevieve's home and she has had a DNR in place. The DNR is up on her refrigerator, which is the universal location that healthcare providers look for that. She has one in place. That means that if she's already passed away, I'm not going to attempt to bring her back to life. I find her on the floor. I check to see if she has a pulse. She doesn't have a pulse. Her heart is no longer beating. She's not breathing. Her lungs are no longer working. In that case, that medical order says it's okay for me to not attempt to bring her back to life.
And Abigail, as the layperson on the team, I remember when we first started having these conversations, even my own need for clarification about the DNR. Because when I first heard about it, it was frightening, because I used to hear DNR, do not resuscitate, and think DNT, do not treat. So I wonder if for our audience, if anybody has the same uncertainty or fear that I used to have, can we clarify in that same scenario, if you came in and I still had a faint pulse, or perhaps my breathing was labored, would you still help me if I had a DNR?
Great question, and absolutely.
Okay.
So I would assess you, see if you have a pulse. If you have a pulse, that means that your heart is still beating, which means you're still alive. So in that case, I'm going to start the necessary actions to take care of you.
Okay. And I think my last question, I'm going to age myself a little here. I was the generation of Grey's Anatomy and ER. And I always wondered, they make it look so easy to bring someone back to life. Maybe they yell clear and they restart my heart. Even in reflecting on what my own personal wishes are, sometimes I'm unclear, if you were to found me and I had already passed away, what would be the benefit? Like, could you try?
Great question. Great question. And Hollywood has done a fabulous job at making resuscitation and jumpstarting people back to life very easy and very commonplace and an everyday occurrence. The reality of the situation is if somebody has some kind of an event, either a cardiac event, so your heart, or a pulmonary event, your lungs, those are major organ systems. And if somebody has a problem with one of those systems and those fail, and the person subsequently passes away, the likelihood that even if that happened to Genevieve, who as a young, healthy person, if I immediately started CPR on her, called 911 for paramedic backup, the likelihood that I would be able to jumpstart her, bring her back to life, is actually very low. Even less likely is that even if I were able to bring her back to life with the assistance of the paramedics and the specialty equipment that they have, the likelihood of her having good brain function and good body function that it was prior to the event is very low. So the reason that that's important is if we think about our average patient who's a few decades older than Genevieve that have medical problems, that decreases the likelihood of success. And even if there is that initial success, of a good outcome where brain function and body function are working properly. And why it's important, even though it's uncomfortable to talk about these things ahead of time, is without a DNR in place, even if we think that the patient wants that and that they would not want to have a bunch of pounding on their chest and shocking and a tube down their throat and all of those things, without the DNR in place, it sets off a chain of events that often end up in hospitalization and death, or hospitalization and severe brain injury, and ultimately death. So we like to talk about that ahead of time to be proactive instead of trying to figure out what to do in a crisis.
Abigail, thank you so much for going into more detail about that, because I think, even in the conversation that we just facilitated with each other, that's again an example of the types of conversation that you would have while advanced care planning. And again, reinforcing the importance of advanced care planning, why we're here to talk to you today, is having those conversations proactively helps prevent us having to react in those crisis situations. So even talking through, what scenario would I choose to have CPR withheld? What scenario would I wish to be a DNR? Sharing that then with my family members, because even God forbid, I ended up in the hospital, perhaps in the ICU on life support, having my advance directives written, having my family aware of what my wishes are, ultimately ends up being a gift to them, because they have guidance as if I were sitting right next to them, telling them what I would want them to do in this situation. So it again also alleviates any further burden for care or decision making from my loved ones. So it really is a win-win situation for everybody involved to have these conversations ahead of time and to put the outcome into writing.
So let's talk a little bit more, go a little bit deeper about, really all of the things that we are trying to accomplish with advanced care planning. One of the main things that we want to do is to help our patients stay out of the hospital. That's a big goal, not only that nobody likes to be in the hospital, but also we understand that especially in the face of chronic illnesses, with every return to the hospital, even if you leave the hospital and are functioning, you're a little bit weaker than you were when you went in before.
I think it's really important, again, and you'll hear this as a theme throughout, that Abaco and I, in our daily interactions with our patients, we're never there to say what their decisions should be. We're simply there to educate, empower, and support their own complex medical decision making. We often tease that when we go in to buy a car, we might research the model and research, does it get the gas mileage? Is the engine reliable? We're really an informed consumer. And that's what we want for our medical consumers. When you enter the healthcare system, you are a paying customer and wanting to be able to participate in your plan of care to make informed decisions, again, based on your own personal values. I think too, as we've talked through, even its name, advance, it really, again, speaks to why this is so beneficial to do ahead of time. A phrase we use often is that we don't pick the fruit the same day the tree is planted. So planting this seed of thought, of consideration, what do I want if this should occur, really helps us streamline the transition into hospice care if and when we come to the point that that's perhaps the best next step in our plan of care. Breaking down the myths and the taboos that we know and Abaco spoke to are still so present in our cultural view of death and dying. And ultimately nurturing a continuum of care, from birth to death. We would strive that every patient, every member of our community have the best potential for the most positive experience throughout that care journey.
So Jen and I are always excited about any opportunity that we have really to share some highlights of our success stories. And I should add here too that it's been over 2 years now since the inception of our program, and we've had the privilege, and it really is a privilege, of speaking with hundreds of patients. So these are a couple of them. The first patient that I'm going to share with you, we'll call Mr. B. And this very nice gentleman was a recent retiree to Vero Beach. He had just retired and relocated and was going to enjoy his retirement playing golf. He had always been pretty healthy. He had some high blood pressure, some high cholesterol, which is fairly typical in that age group and demographic. But other than that, he had not had any major medical issues. He'd been here in Vero Beach for a couple of months when he started having pretty severe abdominal pain that prompted a visit to our local emergency room. In the emergency room, he received a devastating diagnosis that he had advanced pancreatic cancer. Within a week, he had started chemotherapy and radiation treatments, and he had become very weak. when we were asked to see this gentleman by his home health care nurse, she had identified that he and his spouse would benefit from advanced care planning. In addition to Mr. B having terrible abdominal pain, his wife was also very overwhelmed and was not sure what to do. He was hurting. He was becoming immobile. He was having terrible nausea, and she did not know what to do. We saw Mr. B for the purposes of advanced care planning and talked through what his goals of care were. He had two biggies that he wanted addressed. Number one, he was concerned about his belly pain. He's had this diagnosis now for a couple of weeks, and he's had the pain for several months, and it's still a 10 out of 10, and he is exhausted from that. Secondly, and maybe more importantly, he was very concerned about his wife. He was concerned about the toll that his illness was taking on his wife. Ultimately, Mr. B decided that hospice was most in alignment with his goals of care. We were able to get him admitted to hospice later on that day, and even better, get his pain under control later that day. Mr. B lived for a further 63 days on hospice, which is pretty typical for a patient with pancreatic cancer at that stage, unfortunately. But the good thing about that is that those days were pain-free. He was supported by hospice, as well as his wife being supported by hospice. We really like to highlight here for this gentleman in particular that in a typical case of somebody with an advanced cancer diagnosis such as his, the end of life experience and the dying experience would have been dramatically different for him and his bride. Usually what happens is as the patients continue to decline and weaken, they need to return back to the hospital. And as I mentioned earlier, with every hospitalization, even though we get fixed up temporarily, we come out weaker. In the end, Mr. B was able to choose how he wanted the remainder of his life to go. He was able to stay at home, be comfortable, be near his wife, and his wife was supported and able to function in the capacity of wife instead of overwhelmed caregiver. Our second patient, Mr. D, is one of our favorites. This was a very sweet 93-year-old gentleman who had actually been on home health care services with our agency intermittently for a couple of years before we ever met him. He had some worsening congestive heart failure, and he was seen by home health for services after some of those hospitalizations for exacerbation of his heart disease. He had always been a very compliant patient, A+ star pupil, and always followed medical orders. So one of the medical orders that Mr. D followed faithfully was the application of his very tight compression stockings for the purposes of controlling the edema that happens based on his heart failure. In the process of putting his stockings on one morning, Mr. D suffered two separate spinal fractures in his vertebra while he was trying to get his stockings on. He was subsequently in terrible pain. Jen and I were asked to see this very sweet gentleman for the purposes of advanced care planning because he and his children were weighing out the possibility of a future kyphoplasty. And what a kyphoplasty is, for anyone that doesn't know, is when you have a spinal fracture, they actually pry open that fracture and then squirt in some cement into the fracture for the purpose of stabilizing the fracture and hopefully reducing the pain. In further talking to Mr. D, he really didn't want to go back to the hospital. He wasn't particularly interested in having surgery. He was really pretty realistic that at 93 years old, the odds of him being able to even undergo the surgery due to his heart disease were low. And even if he was able to undergo the surgery, what might his recovery be like? And would it even work for the purposes of controlling his pain? It was a great opportunity to talk through his situation and the options, both with him and with his adult children who were very involved in his care. Ultimately, Mr. D chose home hospice. We are delighted to report that our star pupil was admitted to hospice. He also got his pain under control quickly and was able to get up and move around. One of his favorite things was to walk laps at his assisted living facility where he knew all of the residents and was friends with everybody. To the point that when our social worker on the hospice home team went to make a routine visit, he waved at her and said, "I always love to see you girls. I can't talk today. I'm busy. They're having live music down in the dining hall, and that's where I'm headed." So we like to use him as our final example of our positive outcomes. You know, what a beautiful example of that benefit of having those conversations ahead of time. Even though they're scary and sometimes unpleasant, he had an opportunity to choose what he wanted. And we're happy to report he lived on hospice for almost 10 months after being admitted. And most of that time, he was up and around walking his laps at the ALF, able to participate. You know, we feel that that's a real testament to the benefit for him of advanced care planning, as well as really highlighting how everyone can benefit from advanced care planning.
Thank you, Abaco. Those really are two of my favorite stories because, again, as Abaco said, they reinforce the importance of those advanced care planning conversations. The other reason two of these are my favorite stories is because they also dispel quite a few of the myths that surround hospice. Both Mr. B and Mr. D were able to stay in their home settings. You know, sometimes people hear hospice and they think it's somewhere they have to go, and that's not the case. The goal of hospice is really to keep our patients at home for as long as possible. The other thing, Mr. D in particular, you know, almost 10 months with hospice support. Many times people hear hospice and they think it means I'm knocking on heaven's door. I only have days left of life. And that's not the case. We often say our ideal minimum length of stay for someone with hospice would be 6 months. That's the minimum we want per that Medicare criteria that makes someone eligible for hospice. And I think, and this is a statistic that Abaco shared with me, you know, the stark contrast that we see of the dying experience for those patients who have had versus those who have not had advanced care planning. You know, both Mr. B and Mr. D were surrounded by their loved ones in a setting familiar to them at home. Whereas I think, Abaco, you say it's 1 in 5 patients
Correct.
will ultimately pass away in the ICU. And it's not that 1 in 5 patients die.
So it's 1 in 5 Americans, their life will end with death in the ICU. And we like to contrast that or just compare it for clarification that it's not that 1 in 5 ICU patients die. It's 1 in 5 Americans. Their last breath will be in the ICU.
So knowing that staggering statistic, again, the importance of advanced care planning to help as much as possible prevent that from occurring. You know, this really is something that you can do for yourselves and for your loved ones when everything is out of our control in those situations, to as much as possible empower choice of where it takes place and what it looks like. So really our takeaway for today, I think as you can hear, and Abaco and I speak so passionately about advanced care planning, we could probably keep you for the rest of the day. But we thought that this quote from Dame Cecily Saunders, you know, really the founder of hospice, taken from the Oxford textbook of palliative care, was a wonderful summation of, again, why we think advanced care planning is so important. And essentially, normalizing the dying process. So talking about these things ahead of time, moving through the fear of discomfort and discomfort of these conversations by trying to communicate about them openly. It's not only important for the patient, so not only important for Mr. B or Mr. D, but also for their loved ones. You know, Mr. B's wife was nurtured and well supported, educated through her hospice team, that all of the things she were seeing, albeit very hard to bear witness to, were natural, and that she had support to navigate them. You know, Mr. D's children thereafter had a sense of accomplishment and fulfillment in their role of children, you know, taking care of their father in his last days so that he could die doing what he loved most. You know, the manner in which our loved ones pass away will forever remain in the memories of those who live on, and ultimately influence the grief and bereavement processes. So our surviving loved ones, you know, the contrast not only of the dying experience, but their grief and bereavement process. And Abaco, again, unfortunately, have seen, you know, the stark contrast of someone who perhaps was well supported by a hospice team for 6 months, that had advanced care planning conversations proactively, maybe years, even decades prior to ever being diagnosed with an illness. The sense of preparation, opportunity for closure, legacy that it provides, versus someone who, you know, really experiences shock in a moment of crisis without any guidance on how to support their loved ones in the way that they would have hoped for. So we often share too, you know, we always wear our VNA badges. And if we forget, you know, we run into Publix and we leave our badges on, I would say 9 times out of 10, someone might stop us and say, "Oh, you work for the VNA. You took care of my wife. You took care of my son. You took care of my father." And it's personal. You know, it may not have been myself and Abaco that cared for them. It may have not been this past month or this past year. But those memories are so deeply rooted that they see that VNA badge and they identify, and it comes right back. You know, so again, the importance of advanced care planning, affording the opportunity to have these conversations, so that not only is it the best possible dying experience or best possible experience of the entire healthcare journey for the patient, but also for their loved ones that are walking with them side by side on that journey. So with that, we again want to thank you for your time today and affording us the opportunity to speak on something that's so important to us. And we'll pause now to see if anybody has any questions.
Thank you so much, Genevieve and Abaco, for all the valuable information that you provided us today. So now we're going to move on to our Q&A session. So Abaco and Genevieve, we received some questions from some of our participants when they signed up for this webinar. So first I wanted to touch on what are some of the requirements to receive hospice care?
Great question. So to be considered eligible for hospice care, that requires 2 prongs. So both what we call clinical appropriateness as well as philosophical alignment. So the first part, clinical appropriateness, that refers to disease-specific criteria that's set forth by Medicare. And by disease specific, what I mean is for heart failure, for COPD as a lung disease, for cancers. And what that means is that the criteria speak to that medical providers would not be surprised if a patient's life expectancy was 6 months or less, if the disease progressed naturally as expected, without what we would call aggressive measures. So without things like chemotherapy, without things like dialysis. That's the clinical appropriateness. The second part that makes a person appropriate for hospice would be what we call philosophical alignment. And what that means is that the patient has reached a point where they no longer want to pursue those aggressive measures. In other words, it is more important for them to have quality of life and be comfortable and have symptoms managed and let their disease progress as we would anticipate naturally, versus they want to pursue those aggressive measures, things like chemotherapy, IV fluids, dialysis, immunotherapy, in an attempt to prolong life.
Okay. Thank you, Abigail.
You're
Can you
welcome.
speak a little on how hospice care is paid for?
Sure, that's a wonderful question. And finances, it's a concern for everybody. For our Medicare age patients, hospice is covered at 100% under the Medicare Part A benefit. And I qualify that for our Medicare age patients because that's also sometimes a common misconception that hospice is only for the elderly. It's not the case. And for anybody with private insurance, speaking specifically to their providers to clarify coverage is always recommended. But really for reassurance, and this is specific to the VNA, this would vary agency to agency, state to state, but we are a nonprofit organization. So even for our patients that might not have any insurance, we really believe that there should be no financial barriers to hospice care. So anyone needing the support of hospice should reach out because it is something that the team would walk through with you with the support of our financial counselors to ensure that there's no financial barrier to care.
Thank you, Jen.
Mm-hmm.
Are you finding that more physicians are willing to refer to hospice than may have been true in the past?
Very good question.
Mm-hmm.
So we do not have any specific statistical data to really say definitively one way or another. But what I can share with you is that we are finding that the more education that we provide, not only to our patients and their families in regard to advanced care planning, but also to our providers and our medical community about advanced care planning and about hospice, that we are seeing that more of our patients are feeling empowered to request those services, to initiate those conversations with their providers. And that's really our goal. That's why we're doing this. We want more people to know about that so that those services are utilized and that we have more patients who are able to benefit for longer from hospice services.
Mm-hmm.
Thank you, Abigail. So if one has long-term care insurance, how does that come into play for hospice care?
Very good question. So typically long-term care policies are more geared towards what we would call private care services. So to clarify, well, what's the difference between hospice care and private care? So hospice is only ever a supportive service, and it's for the clinical needs of the patient. So the RN case manager, the social worker, the chaplain, all of those interdisciplinary team members are there to educate, train, and support the patient and whoever is identified as the primary caregiver. So again, being a supportive service, it's not that we ever assume the role of caregiver. So many times there is a need for caregiver support for those activities of daily living. So things like personal grooming, food preparation, sometimes even mobility assistance. Those are what would be more considered private caregiving duties. And really similar to our answer about how is hospice paid for? Because those long-term care policies can vary so greatly, we really do encourage individuals to reach out to their specific policy provider to clarify what are the terms of coverage. Sometimes there is a number of hours deemed necessary. There might be a clinical assessment that needs to be completed and submitted. Sometimes even specific agencies, almost utilizing an in-network provider, for example, is necessary. So it's always important to contact the policy provider directly to ask those specific to the policy itself.
Thank you, Jen.
Mm-hmm.
You also touched on how certain types of advanced directives can be confused, i.e. the living will, the last living will, and testament. Can you speak a little more about this and offer some guidance on completion of those additional documents?
Sure. So again, reinforcement that the living will and the healthcare surrogate are specific to healthcare. So again, that is a document that can be drawn up by a lawyer, but it's also something that is available in the community for completion, like 5 wishes form. Clarifying the difference between that and the last will and testament and something like a financial power of attorney. The last will and testament is really specific to finances, personal business affairs, and estate planning. So those documents we strongly encourage seeking legal counsel to complete. As healthcare providers, that's really outside of our scope of practice. So always encouraging that for anything like a last will and testament, questions about a living trust, how to manage, personal finances and affairs in relation to maybe what is occurring in your healthcare situation, we strongly encourage seeking an attorney for legal counsel.
Can you tell us where the 5 wishes are located?
Sure. So depending on where you're located, we always have 5 wishes available at the main office of the VNA. But Jessica, correct me if I'm wrong, many times they're also available at individual physician's office basis our provision of those.
Yes, and then I did drop some 5 wishes off at the main library at Vero Beach yesterday. So the circulation desk has a few copies, and there are some in the front entrance of the library as well.
Wonderful.
Thanks.
And our address is 1110 35th Lane, Vero Beach, Florida, 32960, if you would like to stop by and pick up your copy of the 5 Wishes booklet. So we have a question from one of our participants, Daniel Glover. Would you like to unmute yourself and ask your question?
Yes, I'm participating from Maine. My sister lives in Vero Beach and my father did. But I've recently become involved with a 101-year-old veteran, and he's being taken care of by his 75-year-old daughter, who's my age. And I've just been pitching in the last couple of weeks to try to get them caught up on all of the things that they're not caught up on with regards to getting support for this 101-year-old veteran. So, but when you said clinical definition, we're waiting for a statement from the doctor to submit with a form to an organization called Vet Assist. And I'm wondering, can he just be 101 years old and participate in this program?
So very good question, Daniel. And thank you so much for the background and willingness to participate. So I'm going to give a bittersweet answer because unfortunately, just being the ripe old age of 101 does not necessarily mean that someone is clinically appropriate for hospice. You know, again, speaking to Abaco's specific answer about what makes someone clinically appropriate for hospice is that he would need to have some sort of diagnosis or even a combination of diagnoses that resulted in an overall prognosis. So an overall what the future might hold or life expectancy of 6 months or less. So that through conversations with his physicians, you know, if he has co-occurring diagnoses that would suggest, you know, that they would not be surprised if he were to pass away in 6 months or less, that would certainly be reason enough for them to write a formal order requesting a hospice evaluation from the VNA. And that, again, you said he resides in Indian River County, is that correct?
No, ma'am. He lives in Maine.
Oh, okay. Well, even thank you for clarifying.
Because I live in Maine. My sister just lives in Vero Beach.
Okay.
Okay.
And my father passed away there at the age of 92.
So even with that, then for the specifics would be to ask his physician, you know, if he would have a prognosis of 6 months or less, and then he would still, same process, submit an order to refer for a local hospice to evaluate.
Okay. All right. Well, have you all heard of this organization called Vet Assist?
So it's not one that I am familiar with in Florida. Typically we go through our local VA representatives, but certainly if it's something that you've received guidance on, you know, again, not being familiar with the resources within Maine, I wouldn't be able to speak to that specifically.
Well, you're more familiar than I am, but I'll let you know when I learn.
Well, thank you again for your question, Daniel.
Okay, thank you. Thank you for your help. This has all been very helpful. Thank you.
Oh, you're so welcome.
Good.
Do we have any other questions from any of our participants? If you have a question, you can go ahead and unmute yourself. Okay. Well, thank you so much, everyone, for joining us today. If you want to learn more about the VNA, please like us on Facebook, follow us on Instagram. Did someone have a question? Okay, I guess not. It was probably
that was just a thumbs. That was a thumbs up. Well done.
Oh. And you can also sign up to receive our e-newsletters on our website. And like I previously stated, if you would like a copy of the 5 Wishes booklet, you can stop by the VNA's headquarters, which is right behind Cleveland Clinic Indian River Hospital. So this webinar has been recorded and will be available on our YouTube channel in the next coming weeks, if you would like to view the presentation again. And if you have any additional questions that come to mind about this presentation or hospice, please feel free to reach out to me. My email address is jnettles@vnatc.com. If no one else has any questions, have a great afternoon and a nice holiday weekend.
Thank you, everybody. Have
Thanks
a great day.
Thanks so much. Bye-bye.
Bye.